I'm going to talk about a different case, and I'm going to talk about the case of a 54-year-old man who has been diagnosed with HIV infections in 2004 and started antiretroviral combinations in 2006 with TDF, emtricitabine, and nevirapine. Recently, 6 months ago approximately, he had acute hepatitis C and he treated it with Arvoni for 8 weeks, and his HCV PCR is negative today. He's well. If you ask him how he is, he says, yeah, he's well. He buys sildenafil online, and that is the only co-medications that he reports. In terms of recreational drugs, he reports the use of poppers only, and he says he doesn't drink very much. His blood pressure is 170/98, but you know about it because you received already a letter for the general practitioner that asks you whether he can start amlodipine 10 milligram once a day. And I would like to link this thought to the talk of our colleague cardiology earlier that says, as cardiology, we don't need calcium channel blockers, which is really important for us HIV care providers because we are worried about drug-drug interactions between calcium channel blockers and antiretrovirals. And also we work with general practitioners about managing blood pressure, and maybe more specialist advice from cardiologists sometimes is useful in this kind of patients. So what do you think about nevirapine and amlodipine? What do you reply to your GP, to your colleague? Are you happy?
It might not work.
It might not work, exactly. So.
It might work.
It might or it might not. But in 2017, almost 2018, I mean, basically it's Christmas tomorrow, you can do something about it because there is no study looking at the interactions between nevirapine and amlodipine, but theoretically, because of a potential induction of cytochrome P453A4, and which is one of the metabolic pathway that amlodipine is a substrate of, amlodipine can be decreased and not work optimally, so not control a high blood pressure. And again, today, with all the options that we have as third agents, you might decide that this patient can be prescribed something else. And also the fact that he's aging, the risk for the number of co-medications to increase over time is high, I think. So his UNEs, LFTs, and full blood counts are all within the normal range, but as you can see, his total cholesterol is raised, and as well as his non-HDL cholesterol. And he's not on a statin. His viral load is undetectable. His CD4 count is above 500. He was exposed to hepatitis A, but he's okay, and he has a good response to hepatitis B vaccination, and he doesn't have any other sexual health infections. So he's well, he's aging, his blood pressure is high, and what other aspects of his health require monitoring? So we're not really in the context where Giovanni was talking. We're not in the frailty context. We were talking about not very old men, but someone aging with HIV. What else do we need to do? Shoot, 2 tests that weren't listed. 2, just give me an example.
STDs, was STD?
No, he's all fine, all negative. Kidney function. It's normal. With Bruce there, I would never say anything different than it's fine. Including proteinuria. No, that's really important. He's on TDF. That's right. Something else? Bones. Exactly. Okay, so do patients with HIV age prematurely? Do we actually need to do a lot more tests to see whether there is neurological impairment, there is a risk of developing cancer earlier, what's the bone health, kidney disease, it's there, liver toxicity, cardiovascular disease. And I think from the talks that you heard earlier today, you probably figure out what should be done. Important, but let's never forget that these people that are aging with HIV and have multimorbidity are also at a high risk of being on polypharmacy, so the importance of drug-drug interactions that has been mentioned a few times already today. So at Chelsea Westminster Hospital in 2009, we actually decided to start a clinic dedicated to people over the age of 50. There's not much more we do, but we do see them with a little bit more time, and we just make sure that the monitoring advised, suggested by the BIVA and or EACS guidelines is actually happening, and the results are reviewed carefully, and liaison with general practitioners occurs timely. So these are the BIVA guidelines for older patients above the age of 50. They're a little bit conservative. Laura, sorry, they're almost perfect, I would say, but they do recommend to make sure we monitor drug-drug interactions very carefully. We liaise with GPs. They don't advise to perform a DEXA scan, but only to measure the FRAC score. So this is in disagreement with the EACS guidelines, and we're going to look at that. They advise to look into patients with neurocognitive impairment, cardiovascular risk, alcohol dependence, and also screening for colorectal and breast cancers is mentioned by the BIVA guidelines. So drug history and drug-drug interactions, I think we'll never get tired of repeating how important it is. But just because drug interactions like amlodipine and levirapine can happen in clinic, and then people worry about blood pressure not responding, not being treated, and it's just a simple drug-drug interaction. So in the over 50 clinic, we go through all the drugs that the patient takes, including over-the-counter drugs, herbal remedies, recreational drugs, and go through again everything in detail, make sure there's no drug-drug interactions in the patients you have in front of you. And obviously, when we can, we use the Liverpool website, as also mentioned earlier. We also do a few extra blood tests that are not in everybody, so they're not done for people below the age of 50, which is for men. We do measure testosterone and free testosterone, and we refer women to the menopausal clinic. We have an HIV menopausal clinic dedicated to aging women, which is very useful. My colleague who runs it says the women are very happy. And we have a little bit of experience with aging transsexual, and it is quite interesting to actually having conversation about how they feel about their hormones and whether there's any drug-drug interactions, because they can have polypharmacy too with hormones. In terms of cancer screening, we measure a PSA in men. These are patients that might not go to see their GP as often as other people. Anal cytology and referral to anoscopy clinic if abnormal occurs. And again, the cervical smear, I think Laura talked about cervical smear enough. In terms of cancer screening, I think it's worth mentioning this data set that comes from the National Cancer Institute that interestingly shows that people living with HIV are diagnosed with cancer at earlier ages than uninfected adults. And this is why at the age of 50, we do perform some type of cancer screening that in the general populations might start at the age of 60 or over. In terms of cardiovascular disease, what we do in the clinic, we measure the Q risk. Now, again, in front of a cardiology, I'm not embarrassed at all about talking the differences about Q risk 2 and Framingham, but I think that, or at least the BIVA guidelines advise to measure the Q risk 2, while the EACS guidelines advised to measure the cardiovascular risk with the Framingham. So the Q risk 2 may underestimate the risk, and the Framingham may overestimate the risk. What we know is that in the Q risk 2, there's room for a few more pieces of information, so we use that. We also are lucky because our hospital allows us to request the coronary artery calcification score, and gave us an algorithm. The cardiologists we work with gave us an algorithm on how to follow up on the results. So we are actually working on the cholesterol control based on the results of the CACS and try to prevent cardiovascular disease a little bit more aggressively. In terms of bone mineral density, again, the BIVA guidelines say a FRAX is enough, so you would go to the website from the Sheffield University and measure the FRAX, but we do request a DEXA scan in people over the age of 50 and measure their vitamin D. Briefly, this is what the EACS guidelines advise to consider a DEXA scan in postmenopausal women, men over the age of 50, history of low-impact fracture, high risk for falls, and use of steroids. And also to measure vitamin D, at least the baseline when you meet a patient, but we do measure it in the over 50 clinic, and if it's very low, obviously we look at the results together with the bone scan and the FRAX and so on. In terms of cognitive assessment, I think that's quite, I think that's the most difficult of all, because there is no standardization on how to test for it among the clinics. So what we do, which is actually not that different from what the EACS guidelines suggest, we ask a couple of questions on whether the patient is concerned about memory, concentration, and cognition, or anybody around has expressed concern about memory, concentration, and cognitions. And these were advised to us from our psychologists, psychiatrists, and neurologists that helped us putting together this short and quite easy assessment. We do investigate quite in depth the social situation of the patient. So I'm sure some of you know their patients very well, have been knowing them for 20 years, but this is not the case for everybody. And if people are referred to the over 50 clinics, sometimes we don't know them, and sometimes they might come only once a year to the clinics, because in the monitoring in London is once or twice a year. So we look at whether the person in front of us may be isolated and, again, overuse alcohol. It might be someone who's always been quite well and had a job, but now is going towards retirement and feel anxious about what can happen next, and financial problems and so on. We see that quite a lot. And actually, I remember talking to our patient activist at Chelsea Westminster Hospital and saying, if I have to report a problem from the over 50 clinic, is depression, sadness, and isolation, because rather than other organic health problems that we know how to manage quite easily. We administer a depression questionnaire, PHQ-9, or an anxiety questionnaire, a GAD-7, and we also administer an everyday memory questionnaire, which is a validated 13 items questionnaire. It's quite intense. I always, usually if the patient doesn't express any concerns about their memory, we don't administer it. It's kind of ask you how many times a week do you put the keys in the fridge. So it's at that level. So the majority of people score very low, but it is very useful to actually identify people with high scores and immediately refer them to the neuropsychological testing. So it's quite useful, actually. This is, again, the EACS algorithm for the diagnosis of HIV-associated neurocognitive impairment, and just to summarize it, as I said, the most important thing is to exclude depression, and then there is a neuropsychological examination, and if that's abnormal, I think you need to talk and work with your neurologist and make sure that a brain MRI is done. And obviously it's very important to understand whether there is active central nervous system HIV infection, and NLP is needed, and then that goes into HIV and kind of neurology, and it's slightly a different area than just the screening the whole aging population with HIV. So what about our patient? Pardon? You want me to finish? I'm done. 2 slides. So our patient needs definite treatment for hypertension. So there, like we said, about potential drug-drug interactions, about nevirapine and amlodipine. I think in 2017 we can give him probably an unboosted integrase inhibitor and like raltegravir or dolutegravir. He also had osteoporosis at his DEXA scan, and so we're now thinking about changing his tenofovir. we can change into abacavir or we can change into TAF. The abacavir, again, Hans-Jürgen was talking about the believers, the non-believers. I think at the moment his cardiovascular risk is 12%. He probably needs a statin, but it's still not controlled. So maybe it's safer to give him TAF, especially if you're a believer about abacavir increasing cardiovascular risk. He probably, do you think he needs a statin with a cardiovascular risk of 12%? No. You don't? Okay. I think he does, doesn't he? 54, high blood pressure, not treated yet, but he will be hopefully. I think he probably does. And I think that the answer of that, I would base it on the CACS, and that's why I find it very useful. If his coronary artery calcification score is 0, we can talk about diet and exercise and give him a little bit more time. But obviously, if it's high, we need to be very aggressive on the cholesterol control. And so if it's above the 75th percentile, we'll actually refer them to cardiology. But we still, then in that case, we probably does need a statin. And I'm done. Thank you very much for your attention.